Good morning, good afternoon, good evening, everybody, to the 2021 ALD Connect annual meeting. I heard that we have attendees from 5 continents. So wherever you are, it's great that you're here. So a warm welcome to from all of us at ALD Connect, to all of you who have tuned in to yet another virtual meeting, to all the families, the patients, to the physicians, the scientists, and to our colleagues from pharma. It's an honor to being asked to open this year's conference with presenting an update on ALD and AMN. But I was asked to start with a disclaimer. To summarize this is that ALD Connect can only provide information and not clinical, diagnostic, and treatment advice. If you're ill, you have to see a doctor immediately. We do not recommend specific doctors, treatments, or procedures, and there is no product placement in this talk. So it's already 2 years ago that we had our last live conference in Boston, and maybe naively we thought or hoped that it would be just 1 year. It's quite impressive how ALD Connect and other organizations quickly adapted to the new reality of online conferences. So our 2020 online conference was a big success, and it was a lot of fun. It was very new to us. And this is the awardees receiving all kinds of prizes. But it is clear that online meetings never approach the experience of a live meeting, where you can meet and talk with everybody during the entire conference. I think that one of the many things that we really do miss online is the spontaneous small talks when you are, for example, waiting in line for coffee or during lunch, that you suddenly sit next to somebody who you've never seen before. So making new friends and connections, sharing experience with families, discussing new experiments, and initiating new ideas or collaborations are just some of those examples of the dynamics of a live meeting that are almost impossible to copy to an online event. But then, that said, there are of course also many advantages. It's easy to attend for more people because you don't need to travel. It's also less expensive, no airfares. There's less time investments, and it's also better for the environment. So I guess we can even say that this is we've organized our second Green Conference. And on a personal note, just 2 hours ago, I was in Luxembourg presenting at an international newborn screening society, and now having the honor of opening the ALD Connect conference in technically the East Coast of the United States. And that, of course, is only possible with online conferences. But I do hope that this kind of meetings will end up next year, because I really do want to see you all again in a live setting. And technically, I'm a little kind of fed up with speaking to computers, not seeing anybody. So back to today's topic. I've been thinking quite a bit of what to present in the opening lecture. And of course, I like to start with a very brief on ALD, a brief intro on ALD. And then I would like to highlight just a few of those so important topics and challenges and goals in ALD. And many of these points are will be discussed in much more detail over the next 2 days. Okay, so the basics. We're talking about ALD. ALD is caused by mutations in a single gene, in the ABCD1 gene. And here you see a schematic presentation of a cell. And in the cell, we have different organelles, like the nucleus, where the DNA is located. And there's also this little organelle, it's called the peroxisome. And the peroxisome is important for the breakdown of very long chain fatty acids. And the ALD gene codes for a protein, the ABCD1 protein, which resides in the membrane of this organelle. And its role is transporting very long chain fatty acids into the peroxisome, where they are degraded. In case there is a mutation in the ABCD1 gene, there is a buildup of these very long chain fatty acids in the cell, and then in tissues and organs, causing disease. And measuring these very long chain fatty acids, and nowadays we specifically measure C26-lyso-PC, is a diagnostic test. It can be used to diagnose males and females with ALD. So all males and females with ALD have a mutation in the ABCD1 gene and a buildup of these very long chain fatty acids in tissues. And that can already be screened at birth. But the clinical presentation of the disease is unpredictable. Patients can develop adrenal insufficiency, and this only in males. Males are at risk of developing cerebral ALD, or the brain disease. And in adulthood, both males and females will develop a spinal cord disease. For adrenal insufficiency, it can be life-threatening if it's not diagnosed, and experience shows that it's often discovered only after several hospitalizations. And the cerebral ALD is a rapidly progressive and often fatal disease. And a bone marrow transplant is curative, but it is only effective in the earliest stages of the disease. And unfortunately, for the adult form, the spinal cord form, or the myelopathy, or also referred to as AMN, this is a slowly progressive disease for only supportive treatment is available. And to make things more complicated, so we cannot predict the outcome whether a child will develop adrenal insufficiency, cerebral ALD, or in adulthood, the spinal cord disease. Males who have developed the spinal cord disease or adrenal insufficiency are still at risk of, on top of that, developing cerebral ALD, and also that we cannot predict. So I would like to start with newborn screening. What is the rationale for newborn screening? Why should we screen for this disease? The rationale is that because the adrenal insufficiency and cerebral ALD can be treated. This is a study that has been done, a collaboration between Amsterdam and Boston. And it's a very complex slide, so I will make it a little simpler for you. So this is the age of patients, and this is the percentage of patients affected either by adrenal insufficiency, brain disease, or spinal cord disease. So now if we focus at the age of 10 years, we can see that 1 out of 2 boys will develop adrenal insufficiency or adrenal disease, and 1 out of 3 boys will develop a brain disease. And for adrenal disease, hormone replacement therapy is therapeutic, and if caught in time, the brain disease can be treated with a bone marrow transplant. So in 2014, with New York State was the first state to initiate newborn screening with the help of Elisa Seeger, and we also have to acknowledge Joe Orsini, the head of the screening lab in New York State. So this is the situation in 2014, and now in 2021, around 23 states, I kind of lost track, are screening for ALD. So these are all the states that are indicated in green. And at this moment, in the United States, more than 60% of all the newborns are screened for ALD. But you can see that there are also still a lot of gray states. So there is still a lot of work to do. And outside the United States, in the Netherlands, we started a pilot for ALD screening in the beginning of this year, January 1st. But in the United States, boys and girls are screened for ALD. In the Netherlands, the Health Council recommended that only boys should be screened for ALD. And so we had to develop an algorithm that would identify boys with ALD. We did that, and we can now already conclude that the pilot is successful. And hopefully ALD will ALD newborn screening in the Netherlands will be initiated somewhere next year. But then you see that now we have 2 little green dots on the world map. So there are a lot of ground to cover. And I think that the best thing we can do is help other United States, US states and countries with their efforts to adding ALD to newborn screening program. So collaboration is important, and you will hear that a lot of time in my presentation. But newborn screening saves lives. That is very true, but it's not the end of it, because how can we make sure that all the newborns with ALD have access to the best healthcare? And how can we make sure that the follow-up programs for every newborn is the same and the best? And for that, it's important to realize that even all of the attendees at the ALD Connect meeting currently know about ALD, but it is a rare disease. So the chance that people who have never heard of the disease is very, very large. So important is that we need to provide information on all kind of ALD related topics, and not just in English, also in other languages. And then the question, of course, is what is the best ALD care? And I'd like to introduce the next speaker already now. That's Mark Engelen. He will present on the international recommendations for the diagnosis and management of patients with ALD, a consensus-based approach. That is a study that's, well, it took the last 3 years with a lot of international ALD experts to come up with international guidelines and for treatment of ALD and care. There's another topic in ALD newborn screening. What if the outcome is unclear? Let me explain this. So what happens if sequencing of the ALD gene results in a new variant? So the C26 lyso-PC is elevated, but it's not in the ALD range, so in the so-called gray zone. And if this, then the question that arises, is this new variant, is it a pathogenic variant or is it a benign variant? In other words, does the patient have ALD or at risk of developing ALD or not? The ALD gene is an interesting gene. There are more than 900 pathogenic mutations in the ALD gene identified already. And they're spread all over the gene. Here we see a presentation of the gene, and all these umbrellas are different mutations. So in this case, we have a dilemma. And this has happened in the last several years. And we've been involved in a number of these cases. And we've developed an algorithm to come to a conclusion in case there is a variant of unknown significance. There are two approaches technically that can be taken. Extended family screening means identifying other males that have the same genetic variants, and in case the biochemistry or the variant chain fatty acids are elevated, then it is an ALD case. If that's not possible, then a skin biopsy from which skin cells are being cultured is and then functional testing is done. That's also an option. So this should result in a conclusion that it is ALD or it is not ALD, which of course has serious consequences. So we can identify patients at birth, but then we have these errors here, these question marks. We really would like to predict the future of an individual that is diagnosed at birth. And the question started already in 1993 when the ALD gene was identified, and when it became clear that mutations cannot predict clinical outcome. But the question is, why do some patients develop cerebral ALD and others do not? And even there are monozygotic twins in which one twin develops the brain disease and the other one does not. If we would be able to predict the clinical outcome, then we could divide newborns in risk profiles. So those at high risk of developing the brain disease and those at low risk, which will have an impact on the follow-up. And even a preventative bone marrow transplant could be a discussion at that time. But it is really finding the needle in the haystack, because where to look? Many researchers have been looking for the last 24 years, trying to find these biomarkers. It can be genetic factors, it can be metabolism, it can be the environment, but most likely it is all of the above. It's a combination of factors. And that is a big challenge for the next years. But there are some requirements that we need to fulfill. So to do that, we need clinically well-defined patient cohorts. That is really crucial. We also need longitudinal follow-up and sample collection. So a biobank with blood samples, skin cells, DNA samples. And this requires international collaboration and probably also multidisciplinary collaboration, because we are generating a lot of data. And then if you find something, it is very important that this is validated in an independent study. So back to the scheme. So I talked about adrenal insufficiency and cerebral ALD and the treatment for that and the reason for newborn screening. But most patients develop the spinal cord disease, for which there is no treatment available yet. There's only supportive treatment available. And the data that has been generated in the past supports the hypothesis that this spinal cord disease is caused by a chronic toxic effect of the very long chain fatty acids on central nervous system cells. So there are two ways to approach this from a therapeutic perspective, and that is, one is counteract the toxic effect of these fatty acids, and otherwise normalize the very long chain fatty acids in the central nervous system. So this is the focus of several research groups, and also from our colleagues in pharma. But then, if there is a candidate therapy available, how do you assess that this treatment is really therapeutic? Studies have shown that the spinal cord disease in ALD is slowly progressive, especially in women. So neurological disease markers and tests like the Get Up and Go tests require 2 years of follow-up in a clinical study. The 6-minute walk test is a little better, but it takes at least 1 year. And unfortunately, patient-reported outcomes do not detect disease progression. So there's a lot of investment on other devices, and I will show too. But wearables, so that track daily activity and balance, are currently investigated if these may help. And there's one biomarker that was published in the last year by 2 groups. It's called neurofilament light. And neurofilament light is released by damaged neurons and brain cells, and you can measure that in the cerebrospinal fluid, which is indicated here in blue, which of course is not so nice. It's not easy to access, but luckily it's already been shown that the levels that you can measure in the cerebrospinal fluid can also be measured in plasma, which is of course much easier. So the 2 studies that have investigated neurofilament light are a study from Amsterdam, in which males and females were investigated, and the results were compared to healthy controls, and a study from the group from Johannes Berger and Wolfgang Köhler in males with ALD and healthy controls. And a quick summary of that. So the neurofilament light levels are higher in patients with spinal cord disease or AMN in both males and females than in controls. In patients with cerebral ALD, they're even higher than in AMN. The study from the group of Johannes Berger has shown that it may be predictive for the onset of cerebral ALD. And what also important is that the levels of this neurofilament light, they decrease after bone marrow transplant. It means that this biomarker is responsive to treatment. So the question is this a valuable readout for clinical trials? Another one is the body sway. Also, yeah, if you think of the Wii Fit from the past, that resembles this. It's a force plate in which you can stand, and it's very sensitive to measure spinal cord involvement. And it's shown in this complex image. It correlates very well with disease severity, the EDSS score, and also, for example, with the 6-minute walk test, which is now the gold standard in clinical trials. And this, I would like to highlight this means eyes closed and feet together. So if patients with AMN need to close their eyes and put their feet together, they really start swaying on the sway plate. And the more severely affected, the more they sway. So this is another very interesting and possible very important readout. So if we want to perform clinical trials in ALD, the current landscape is that large patient groups are needed. And at the moment, 1 treatment can be tested per trial. And that limits, of course, the number of trials and hence drugs that can be tested simultaneously. And as I mentioned it already, it requires, with the current endpoints, it requires at least 2-year follow-up. So the goal and the challenge of the ALD community would be to identify sensitive biomarkers and clinical endpoints to measure the treatment success. And maybe we need different trial designs so that we can simultaneously test different treatments in shorter trials and with less patients enrolled. So if a drug fails, that we have an answer sooner, and if it is very promising, that we also have an answer sooner. To summarize it, and then my final slide, and then I have one more, is on disease models. I like to introduce another speaker. So over the years, many different disease models for ALD have been developed. So we have a yeast model, skin cells, a little worm of 3 millimeters, C. elegans, the fruit fly. There's even a chimpanzee that lived in the Washington Zoo and that developed cerebral ALD. The zebrafish model, the mouse models. There's even a plant with ALD, and then human-induced pluripotent stem cells. Let me introduce that. That is work from our collaborators Vivi Heine and Roberto Monteiro. Roberto Monteiro will present about this topic in about an hour from now. So if you take a skin biopsy, you can grow fibroblasts. And the fibroblasts, you can reprogram these cells to become stem cells. And from these stem cells, you can make liver cells, heart cells, muscle cells, intestine cells, all kinds of cells, but also neuronal stem cells. And these neuronal stem cells, you can further differentiate into brain-like structures, also referred to as organoids. So now we suddenly have the possibility of generating little clumps of brain structures that we derive from skin cells from healthy volunteers and from ALD patients. And this is a whole new, a very exciting, a very important platform to test new medication, to study the biochemistry in brain cells. And I'm sure we're going to hear a lot about these topics in the future. And with that, I would like to stop, but not without mentioning the sponsors that we are very, very grateful to help financially organizing this ALD Connect meeting this year.